The pterygopalatine approach to the maxillary nerve block uses the greater palatine foramen as the insertion point and the pterygopalatine canal to guide the needle to its target. The foramen is usually located adjacent to the alveolar bone, between the distal half of the second molar and the mesial half of the third molar. The pterygopalatine canal travels upward and backward to reach the pterygopalatine fossa. When the needle is inserted to a depth of 30 millimeters for the average adult, the tip will lie 1 centimeter beneath the maxillary nerve. For this injection, a 27-gauge long needle is preferred. The smaller diameter and greater flexibility of the 27-gauge needle facilitates passage through the canal. With the bevel facing down, the needle is bent upward 30 degrees at the hub. Then, as the needle is inserted upward and backward through the greater palatine foramen, the heel of the bevel will tend to contact the posterior wall of the pterygopalatine canal, allowing the needle to deflect anteriorly. Should the needle tip strike bone, there is a likelihood that it cannot be advanced and must be redirected. Both the right and left pterygopalatine canal injections can be made with the operator in the 11 o'clock position. To provide visibility, the patient should extend the neck and open the mouth widely. The greater palatine foramen can be identified by placing a round probe at the junction of the maxillary alveolar process and hard palate. As the probe is moved posteriorly from the second molar, it will appear to fall into the fovea created by the foramen. Topical anesthesia of the hard palate is not easily achieved with conventional preparations. Additional analgesia may be obtained by applying pressure to the injection site with a cotton-tipped applicator. After about 20 seconds, the needle is inserted into the foramen as pressure is maintained and 0.1 to 0.2 milliliters of anesthetic solution is slowly deposited. After waiting 2 or 3 minutes, the needle is advanced slowly through the greater palatine foramen and up the pterygopalatine canal. A pen grasp of the syringe facilitates the gentle probing that may be necessary to navigate the canal. The needle is never forced. If resistance is felt, the needle should be withdrawn slightly and advanced at a different angle. Following needle insertion to the proper depth and negative aspiration, a full cartridge of anesthetic solution is slowly administered. Perhaps 1/10 of canals have bony obstructions that may prevent passage of the needle. If the canal cannot be negotiated, then the injection should be aborted. Excessive force can lead to needle breakage, perforation of the thin medial wall of the canal, or deflection of the needle laterally into the infratemporal fossa. If the needle pierces the medial wall of the pterygopalatine canal and enters the nasal cavity, air will be drawn back into the syringe during aspiration. If the needle is advanced too high in the pterygopalatine fossa, as can happen in children and small adults, blockade of the nerve supplying the orbit can occur. This rare complication can result in diplopia and even temporary loss of vision. The patient should be advised that these effects are transient and will disappear as the local anesthetic dissipates.